Hi guys, welcome to Season 1, Episode 1 of our broadcast. Today we will talk about thoracic outlet syndrome, its definition, the anatomy involved, and the causes of this injury. We will discuss the signs and symptoms, how to assess, contraindications, and massage therapy treatment, our goals of treatment, and the possible home care that we can show our clients. Let's get started.
Thoracic outlet syndrome, or TOS, is caused by compression of the brachial plexus and subclavian vessels as they pass through the cervicothoracobrachial region, exiting the thoracic girdle. Anatomy involved. Scalene muscles. The scalene muscles are a group of three pairs of muscles in the lateral neck, namely the anterior scalene, middle scalene, and posterior scalene. They are innervated by the 4th, 5th, and 6th cervical spinal nerves. Thoracic outlet. The thoracic outlet is the space between your collarbone and your first rib. This narrow passageway is crowded with blood vessels, nerves, and muscles. Pectoralis minor. A thin triangular muscle of the upper chest wall beneath the pectoralis major. The base arises from the 3rd, 4th, and 5th ribs of their upper outer surfaces. It inserts as a flat tendon into the coracoid process of the scapula. Brachial plexus. The brachial plexus is a network of nerves formed by the anterior rami of the lower 4 cervical nerves and first thoracic nerve. This plexus extends from the spinal cord through the cervico-axillary canal of the neck, over the first rib, into the armpit. Subclavian artery. The left subclavian artery is the 5th branch of the aorta and the 3rd branch of the arch of the aorta. The right subclavian artery arises from the brachiocephalic artery, the aortic arch, and its branches. Here is a better picture showing the anatomy of the thoracic outlet. The brachial plexus nerve roots and the subclavian artery are passing through the gap between the anterior and mediascalene muscles. The subclavian vein passes in front of the scalene muscles and they cannot compress it. All three neurovascular structures, subclavian vein, subclavian artery, and the brachial nerve plexus, can be compressed between the clavicle and the first rib. The subclavius muscle and the lower part of anterior scalenus muscle are situated in the costoclavicular space, and they additionally reduce this space. In this image, we could see the subclavius muscle. It originates from the first rib in the medial corner of the costoclavicular space and inserts to the lateral part of the clavicle. It reduces the space between the clavicle and the first rib. The subclavian vein is situated in the medial most narrow corner of the costoclavicular space, and it is compressed against the first rib by the subclavius muscle and the clavicle. The anterior scalenus muscle cannot compress the subclavian vein because the vein passes in front of it. The anterior scalenus muscle can compress the subclavian artery, the vertebral artery, and the brachial nerves plexus roots. In this image, we can see all three scalene muscles. The brachial nerve plexus, the subclavian artery, the vertebral artery, and the subclavian vein are also shown in this picture. The anterior and medius-scalene muscles originate from the first rib. The posterior scalenus muscle originates from the second rib. The anterior scalenus muscle inserts to the transverse processes of the third to sixth cervical vertebrae. The scalenus medius muscle inserts to the transverse processes of all the cervical vertebrae. The posterior scalenus muscle inserts to the transverse process of the three lowest cervical vertebrae. Due to the fact that anterior and medius scalene muscles both originate from the first rib and inserts to the transverse processes of the same cervical vertebrae, they are very prone to develop anomalies. They can be as a one solid muscle mass not divided into the separate muscles. An additional scalenus minimus muscle can develop. They can attach to the first rib with the common tendon. Types of thoracic outlet syndrome. There are a number of types of TOS. One is neurogenic or neurological thoracic outlet syndrome. This form of thoracic outlet syndrome is characterized by compression of the brachial plexus. The brachial plexus is a network of nerves that come from your spinal cord and control muscle movements and sensation in your shoulder, arm, and hand. In the majority of thoracic outlet syndrome cases, the symptoms are neurogenic. Another type is vascular thoracic outlet syndrome. This type of thoracic outlet syndrome occurs when one or more of the veins or arteries under the collarbone are compressed. Another type is what we call a non-specific type thoracic outlet syndrome. This type is also called disputed thoracic outlet syndrome. Some doctors don't believe it exists, while others say it's a common disorder. People with non-specific type TOS have chronic pain in the area of the thoracic outlet that worsens with activity, but the specific cause of pain can't be determined. Thoracic outlet syndrome symptoms can vary depending on which structures are compressed. When nerves are compressed, signs and symptoms of neurological thoracic outlet syndrome include muscle wasting in the fleshy base of the thumb, numbness or tingling in your arm or fingers, pain or aches in your neck, shoulder, or hand, and weakening grip. Signs and symptoms of vascular thoracic outlet syndrome can include discoloration of your hand, arm pain and swelling, possibly due to blood clots in veins or arteries in the upper area of your body, lack of color in one or more of your fingers or your entire hand, weak or no pulse in the affected arm, cold fingers, hands or arms, arm fatigue with activity, and numbness or tingling in your fingers. Also weakness of arm or neck, and throbbing lump near your collarbone. Cause of injury. In general, the cause of thoracic outlet syndrome is compression of the nerves or blood vessels in the thoracic outlet, just under your collarbone or clavicle. The cause of the compression varies and can include anatomical defects, which are inherited defects that are present at birth. May include an extra rib located above the first rib, and we call this a cervical rib, or an abnormally tight fibrous band connecting your spine to your rib. Another cause may be poor posture. Drooping your shoulders or holding your head in a forward position can cause compression in the thoracic outlet areas. Trauma is another cause of TOS. A traumatic event such as a car accident can cause internal changes that then compress the nerves in the thoracic outlet. The onset of symptoms related to a traumatic accident often is delayed. Repetitive activity. Doing the same thing repeatedly can over time wear your body tissue. You may notice symptoms of thoracic outlet syndrome if your job requires you to repeat a movement continuously, such as typing on a computer, working on an assembly line, or lifting things above your head as you would if you were stocking shelves. Athletes, such as baseball players and swimmers, also can develop thoracic outlet syndrome from years of repetitive movement. Pressure on joints. Obesity can put an undue amount of stress on your joints, such as carrying around an oversized bag or backpack. Pregnancy also can cause TOS because joints loosen during pregnancy. Signs of thoracic outlet syndrome may first appear while you're pregnant.
So we have 3 to 4 scalene muscles. Most people just have the anterior, middle, and posterior scalene muscles, but some people have this scalenus minimus muscle, which is weird. About 50% of people have it. These originate from the transverse processes of C2 through C7, and they go down and forward and insert onto the first 2 ribs. In order to find these, first we're going to need to isolate 2 muscles. We're going to need to isolate the SCM. If you would like to know more about the SCM or how to work with it, go check out my SCM video. It'll pop up in a little bubble. But find your SCM, palpate both heads, the deep head and the superficial head, and then move lateral and posterior to that. So we're going this way. And now we need to find levator scapula. To find levator scapula, palpate the very side of your neck, and then you're going to bring your shoulder way forward and then raise it up. You're going to feel 2 things jump out. One is going to be a vertical muscle going straight up and down. That's your levator scapula. You're also going to feel one that's at kind of an angle that is posterior to that big finger-like muscle. That is superior trapezius. So once you've found SCM and you've found levator scapula, between those 2 there will be this triangle where you can access the scalenes. So feel between those 2 muscular landmarks and you'll feel kind of a flat field of guitar strings. They're going to be twangy, they're going to be gristly. Get used to that texture. If you're on that twangy guitar stringy texture, you're on scalenes. You'll notice that levator scapula has its own texture. Sternocleidomastoid has its own texture. So this feel for the texture, I think, is the best way of finding the individual scalenes.
Hello, I'm Joe Muscolino, and I'm going to be showing you palpation of the pectoralis minor muscle. The pectoralis minor runs from the coracoid process of the scapula to ribs 3, 4, and 5. To find the coracoid process, we first palpate the clavicle. The lateral or distal clavicle has a concavity. We find that concavity and we drop immediately inferior off of it. And here is the coracoid process right here. From here, there are 3 slips for the pectoralis minor muscle, going over to rib 3, rib 4, and rib 5. Now we can try to palpate the pectoralis minor through the pectoralis major with the pectoralis minor relaxed. If her pec major is tight, we won't be able to do this. However, if the pec major is loose, and especially if the pec minor is tight, which is fairly common, we can feel the pec minor fairly easily through the pec major. And we always do it by going perpendicular to the direction of fibers of the muscle.
To do the Edson test, bring your patient's shoulder into external rotation, slight abduction and a little bit of extension, and try to palpate his radial pulse. Then ask your patient to extend his head and to rotate towards the tested shoulder. And ask him to breathe in and hold the breath for a little while. For this test to be positive, you are looking for the reproduction of your patient's symptoms or for abolition of the radial pulse. The Rose test can be performed in sitting or standing position. Ask your patient to abduct his shoulders to 90 degrees, to externally rotate, and to flex his elbows to 90 degrees. The elbows should be slightly behind the frontal plane. Now ask your patient to open and close his hands for 3 minutes. The test is positive if your patient experiences heaviness, ischemic pain or weakness of the arms, or numbness and tingling of the hands. Also look for discoloration of the hands. Minor fatigue and distress are not a positive test.
Goals of treatment: release adhesions causing contractures and nerve entrapment, reduce muscle spasming. We will work on all muscles of the shoulder, neck and upper back, scalenus, trapezius, SEM, pectoralis major and minor, subclavius, rhomboids, and we will use trigger point therapy. We will correct postural deviations. We will look at the whole body and see how the shoulders and neck are influenced by the lower body. And another goal would be re-educating and increase awareness of posture. Treatment plan: hydrotherapy. Deep moist heat can be used over hypertonic muscles, and cool hydro can be used to edematous tissues. In prone position, basic massage techniques can be done on the upper back and muscle stripping on the trapezius. Ischemic compressions and muscle strippings can be performed on the trigger points that refer to the medial hand. In supine position, myofascial release can be performed on the neck, shoulder, and chest. In working on the scalenes, sternocleidomastoid treatment, muscle stripping, petrissage, and ischemic compressions. For pectoralis major muscles and minor muscles, again, muscle stripping, myofascial release, petrissage, and GTO can be performed. With regards to the subclavius muscle, muscle stripping can also be performed. In side lying position, same procedures can be done. Myofascial release, petrissage to the neck, shoulders, and latissimus dorsi, and petrissage to the pectoralis major and minor. Before proceeding with our treatment plan, we should go over some contraindications that we should watch out for before proceeding. We should avoid placing deep moist heat over the heart. We should avoid deep moist heat in the anterior neck if client has hyperextension and atherosclerosis in the neck. Deep muscle stripping should be avoided on atrophied muscles. And aggression mobilization technique should not be done if the client has a cervical rib, rheumatoid arthritis, or degenerative disc disorder in the cervical spine. Lastly is home care tips, which is stretch the sternocleidomastoid, scalenes, and pectoralis muscles, and strengthen upper trapezius and rhomboids.
So we're going to start with my favorite move, which is spreading laterally with an open hand and spreading medially and superiorly with a soft fist. These anterior and lateral neck muscles are also muscles of inspiration, of breathing. So if I have my client breathe while I'm doing this technique, that's going to engage that fat in a different way. Muscles are going to be sliding underneath my hands. Okay, so now that I've got all of this nice real estate exposed, I can do some unilateral slow exercise. I can feel under my thumb this tight border of anterior trapezius where it rolls over on itself up here. As I work my way up onto the lateral neck, I can feel myself going over sternocleidomastoid and over levator scapula. And in here, you'll feel kind of a guitar string kind of sensation. Lots of little tiny muscles. And these are the scalenes. But what if I want to get more into this anterior neck? What if I want to interact with these fascial sheets a little more directly? I'm going to use, it's going to be shaped like a fist, but I'm really using the flaps of these phalanges right here. I'm going to start with these flaps and move into these flaps. It's going to look a little something like this. Restraining the head with just a gentle hand. Applying pressure down toward the table, not so much in toward their neck. For some clients, this can feel uncomfortable. It can make the skin feel like it's being ripped off their body. So, track your client's face. Most people it's fine, and I actually love this sensation. Looking into the flaps of my proximal phalanges. And follow this down. Alright, let's work with this tissue just below the clavicle. As you follow the inferior aspect of the clavicle, as you follow it laterally, you're eventually going to come across this bump. This is the coracoid process. This is the process that your porcobrachialis attaches to, and your pectoralis minor. Pec minor is deep to pec major, so if we could scoop off her pec major, we'd be able to see it. It runs from this coracoid process down a few ribs and attaches onto those ribs. This is another muscle of inspiration, especially forced inspiration, sniffing, or breathing really hard when you run. So if you're noticing a theme here, yeah, all of these muscles, one, bring the head forward, bring the shoulders forward, and they're involved with chest breathing. People who are stressed out do a lot of chest breathing. So I'm doing a bit of a pin and stretch here. These fingers are contacting the coracoid process. These other fingers are gently gliding down that pec minor, making contact with all of those tendinous attachments. But with this arm here, anything that you do to the shoulder involves a little bit of movement at that shoulder. We're changing the angle as we work. So I'm going to cradle this shoulder, and I'm starting with just some nice mobilization. I'm not really sliding over skin, I'm doing some deep friction where I'm sliding skin over underlying structures. So we're freeing up that deltoid, freeing up that pectoralis major where it inserts onto the humerus. You can come back up onto the trapezius a bit and get some traction in there. If you really want to free up that trapezius, you can slide a thumb under its leading